Thank you for that very wonderful introduction, Ray. And it's lovely to be back. And this is kind of what my dream was, is to also come back and talk about something that I'm pretty passionate about. And I've had the fortunate opportunity, even throughout fellowship and primarily throughout this past year, to really get a large exposure to providing extracorporeal life support, primarily ECMO, but also kind of working with that in the critical care setting. I've learned a lot, and I've learned, had a lot of different viewpoint changes and understanding of our role of these things. And so I hope to try to impart a lot about that on you, but primarily we're going to kind of lay a foundation of what is the role of extracorporeal support and talk about its limitations and its benefits as well. So the subtitle, as you saw in just briefly for a second there, is going to be, yes, it has a role, but know when to say enough is enough. And we'll get into that a little bit more in a second. So I have no specific conflicts of interest to disclose that are official. However, for those of you that know me pretty closely, that is not entirely true. Because I am actually the son of an ECMO pioneer, of someone who had been doing so since the 1980s and had been involved with ELSO for a long time, and has actually been a part of the development of the therapy and device throughout the time. So I think that's a pretty big conflict of interest that I think you should know about. So, okay. All right, so we're going to talk about our objectives. We're going to describe the physiology of ECMO. The reason that I'm going to go through this is because it really defines the core concept as to why it's applied to various different disease states and what it's utilized for. We're not going to go too heavy into that, but we're going to use that to then springboard onto a role of what we are going to use ECMO for, and subsequently other forms of mechanical circulatory support, and how they're going to be applied in the management of these patients in shock. We will also talk about the different types of mechanical circulatory support, understand the differences between them, spend a little bit of time on that. And then I'm going to focus a good amount of the lecture on the discussion of the outcomes of VV ECMO and VA ECMO, so that you're kind of understanding of what's the current state of the literature, what's the current understanding of everything, and then where are we going to kind of go from here. And so a lot of this stuff I actually was fortunate to cater from the most recent ELSO conference, which is honestly probably one of the best conferences that I've ever been to, and really appreciated the candid discussions and arguments about the future of this application and field. So, okay, so what is ECMO? So on the left is probably one of the most common devices that's out there right now. This is the McKay CardiaHelp, kind of a self-contained extracorporeal life support circuit that's utilized for transport. The actual circuit hooks onto it. Everything can kind of fit on the patient bed, and the patient can be easily transported, moved around, and it probably advances one of the represents like one of the biggest advances in the ease, portability, and implementation of ECMO. On the right, you actually have good, there we go. On the right, you actually have kind of an older setup. But that represents really kind of what is actually going on as it separates the pieces, whereas this is all self-contained. And so the idea is that the patient is cannulated, and depending on how the patient is cannulated, whether it's in the venous system alone, such as in VV ECMO, or in the venous system and the arterial system, such as in VA ECMO. But the concept is pretty much the same. Blood is taken out, run at an average of like 4 to 5 liters per minute VV ECMO, up to like, and sometimes even a little bit ECMO. And then the blood is then brought through an oxygenator panel. Okay, no problem. All right, so the blood is then brought through the oxygenator, which essentially is the lung. So the pump is the heart. It's a centrifugal pump, circulates the blood, generates the flow of about 5 liters, runs it through the oxygenator, where gas exchange occurs, oxygen is delivered, taken up by hemoglobin, and CO2 is then removed through a sweet gas that's then returned to the patient. So if it's returned to the venous system, it's called VV. If it's returned to the arterial system, it's called VA. Obviously, the VV system, it does not provide any form of cardiac support, just lung support, whereas the VA system actually does do both cardiac and lung support. So, there we go. So a brief history behind this is there's actually a physician, his name's Robert Bartlett. He's kind of widely considered the grandfather of ECMO. He, back in the 60s, was working as a surgeon out in California and came across a patient who had a pretty massive pulmonary embolism. Patient was there for surgery, kind of doing other things. They diagnosed the patient with a massive pulmonary embolism, but was in obstructive shock, unfortunately died. And he was thinking that there's got to be a better way to kind of manage these other patients. So he was actually working in a lab with a PhD named Drinkler, who had been actually working with extracorporeal support systems and trying to see if they could improve bypass for cardiac surgery and other aspects. And so he's worked with that group for a very long time and pioneered a lot of this field, especially back in the time when IRBs were a little bit different and things were a little bit different in the way that research was performed and implemented. And so, he was essentially the person kind of made for pushing all of this, and then subsequently has moved to the University of Michigan. He's now retired, but moved to the University of Michigan and started up a lab to focus on the development of this. So the reason I show this picture is to demonstrate the kind of long ways that things have go. This is from 1971. This is the first patient that was ever put on extracorporeal life support to try to manage from that way. This patient had ARDS, polytrauma, multiple other issues, and probably really just had significant fluid overload from what we know now. But this is the membrane lung, this giant device. They didn't actually have all of the polymers and the advanced plastics and things that we utilize now. And these were all just flat metal sheets in which the blood would just drip across the metal sheets, oxygenate with air that would go across it, drip down through all the rest, and then come. And as you can imagine, the body did not like that at all. And this patient died. So however, he then, a couple years later, utilized it for the first time in a neonatal patient that was born prematurely, was unable to be ventilated and oxygenated. That patient actually survived and is still alive to this day. And that kind of represents really the first hallmark, even in the 70s, of the first utilization of ECMO. And it's changed and it's come a long way from there. So what is the ultimate goal of ECMO? The whole problem in cardiac and respiratory failure is a problem with either the uptake and or the delivery of oxygen, right? And so we can take it back to our basic physiology of the concept of the delivery of oxygen is determined by the oxygen concentration and the cardiac output. In cardiac failure, it's a cardiac output problem. The heart cannot generate enough cardiac output in order to deliver oxygen adequately to the tissues, subsequently developing cardiogenic shock. The respiratory failure is an oxygen content issue. The lungs don't work so that we cannot oxygenate the blood that is passing through the pulmonary circulation in order to then subsequently deliver cardiac output, but generally cardiac output is reserved. So by understanding these concepts, the idea and the role of ECMO is to provide a support mechanism to replace the failing organ of this aspect and allow for a bridge to something. And we'll get into that aspect in a second. So in normal circulation, we won't go into the full details of this, but just to kind of, I like the schematic and diagram separating the pulmonary circulation and the systemic circulation here. But ultimately, we will have oxygen that's taken up by the lungs by a certain amount. The cardiac output will then deliver that oxygen. That oxygen is being consumed by our body to a certain amount. Then that kind of represents the venous sat on the side as how much oxygen was utilized and consumed and delivered over here. We actually have quite a big compensatory mechanism. We only utilize about 1/5 of the oxygen capacity that we have. So by the time that you get really, really sick, you've actually pretty much gone through the maximal amounts of compensation and issues from there. So however, when we have respiratory failure, right, the lungs are out, we're not doing that O2 uptake, and subsequently are having oxygen delivery issues. And when we are in cardiac failure, we have a pump problem, right? So whether it's an obstructive shock, acute myocardial infarction, decompensated heart failure, dilated cardiomyopathies, or other sorts in which we just cannot generate that cardiac output in order to deliver adequate oxygen to the tissues required for the consumption, and we get that mismatch. And so just to demonstrate the difference between VV and VA, it's really kind of think about it as how it's organized throughout the system. So the heart and the lungs are going to generate, take up oxygen, push blood through the systemic circulation, and return it from there. In VA ECMO, we're bypassing the heart and lungs, taking some of that flood of blood, diverting it through the artificial system, and then delivering it back to the systemic circulation. In VV ECMO, we're taking blood out of the venous system, delivering it back to the venous system. So it's actually almost kind of like a parallel system. So we're just oxygenating the blood before it gets to the heart and the lungs, so that the lungs don't really have to do their job at all. And so when we represent that on our physiological diagrams, this is the concept for VA. We're taking blood from the right side, bypassing the pulmonary circulation, bypassing the left ventricle, and delivering blood directly to the systemic circulation. That then causes some problems. The heart actually can work a little bit harder, but that's often offset by the fact that the amount of blood going through the heart is reduced as well too. But if the heart isn't working at all, then it becomes a real problem. But we won't go into those full details. But the idea is to deliver some augmented form of cardiac output so that your heart can match, plus your heart's native function, plus the ECMO's function will meet the oxygen delivery and the oxygen demand. And the same thing, even without ECMO, performing some other type of device is utilizing the same concept, increasing that cardiac output. And in VV, even simpler, where we're just taking the blood out of the venous system and putting it back into the right atrium, completely oxygenated, so that even though the lungs aren't doing much, we're still delivering an adequate amount of oxygen. So what are the different types of mechanical circulatory support? And so we talked about VV ECMO, which is not really a mechanical circulatory support, just a lung support. But when we compare VA ECMO, there's actually a lot that has been developed and changed over the past decade. And so one of the first forms of mechanical circulatory support that we can think of is the balloon pump. And the balloon pump actually is not pumping anything. It's not generating forward flow primarily. What it's actually doing is, as it deflates, it reduces the afterload of the left ventricle. And then when it reinflates, generates an increased flow to the coronary perfusion, augmenting the diastolic pressure, offloading the left ventricle, making the left ventricle do less work. So your oxygen consumption is decreased and your perfusion of the coronaries is increased. And so it's a really elegant concept, but as we'll talk about in a little bit, it hasn't really shown a significant outcome in the management of these patients in shock, and we'll talk about why. So from there, we then have the concepts of the microaxial flow. That is the impellus that you'll hear about. So the idea is this motor actually goes directly across the aortic valve, pumps blood out of the left ventricle into the systemic circulation, generating more cardiac output than the heart normally could. We have this transeptal. This is actually the tandem heart. The idea from this is that a catheter is inserted across the atrial membrane. So blood is drained from the left atrium, the right atrium, and then given to the systemic circulation. It's very much like ECMO. It's just a very different part, and it's not primarily utilizing oxygenated blood. It's just primarily providing a pump. And then VA ECMO, we talked about ad nauseum a little bit before. And then, of course, we have the implantable surgical devices thought of as LVADs. And so they're actually not all continuous flow entirely. They're working on some more pulsatile type stuff, but that's one of the movements from there. But that's really all about the left heart. We also have another side of the heart. And that other side of the heart can also be supported now, in which there are specific catheters that are designed to bypass the right heart, to put blood directly in the pulmonary artery. So we're essentially bypassing just the right ventricle, supporting the right ventricle in that means. And so very similar methods and concepts. It takes blood essentially from the right atrium, then pumps it, or from the systemic venous system, and then pumps it back to the pulmonary arteries. Or here, there's just some fancy catheters called the Protect Duos and other stuff that has come out that do the same thing, essentially with an ECMO circuit. And then, of course, there's a surgical method in which we take a right ventricular assist device and implant it there. People have actually done both. You can have an RVAD and an LVAD, essentially kind of have a mechanical heart really at that point. You know, the outcomes of that are not that great, but we'll talk about things a little bit more. So that's kind of the summary of the different forms of ECMO and the different forms of mechanical circulatory support and what they can do. So before we move on to kind of the outcomes and what the concept and patient management is about, we'll talk about this one big concept that I like to describe to a lot of the fellows and anybody that talk about this, is that ECMO is not a therapy. It is not something that provides an actual therapeutic intervention that will improve the patient. The only thing that will improve the patient is fixing the underlying problem that generated that issue. And that is the inherent problem with the majority of all of the issues with mechanical life support. So if it's applied to a patient who has an irreversible condition, or if it's applied to a patient who's in end-stage circulatory failure or other stuff, there's nothing you're gonna do. You're gonna deliver oxygen to the tissues, but those tissues will still die. And there's kind of a point of no return. But also, it's really this concept of avoiding further harm based on the other alternative therapies that we're providing. And so what I mean by that is that that's really a different paradigm shift in the way that we're providing critical care and management and support. And that's really the role that ECMO has. And I'll talk about how it's kind of gotten a little bit away from that, and we'll talk about some of the reasons why. But the whole idea is that our current therapies are either doing harm or are inadequate to support the patient in a reversible condition that we think will get better, or towards a definitive therapy such as an implantable LVAD, or such as a lung transplant or a heart transplant, or something in which the patient would benefit from. Ultimately, they just didn't quite make it. As we're learning a little bit more, sometimes the organ just needs a little bit more time to recover, and we'll talk about that in a second. So that's really the idea, and it has helped actually shift a lot of our understanding of ventilation management, the management of ARDS, and the management of cardiogenic shock. And so we'll start with the problems with mechanical ventilation. So the main thing that I want to talk about here, we'll start on the left. And this is actually from the Blue Journal and ETS as a review of the ARDSNet trial. So the ARDSNet trial, you all probably have heard about it, talked about low tidal volume ventilation, using a generous amount of PEEP to maintain and reduce, maintain recruitment and reduce atelectasis. But one of the other secondary analyses by a lot of people, especially in the ECMO community, were interested in understanding this concept that as we were doing a lot of animal trials, realizing that ventilators can actually cause a significant amount of lung injury, ventilator-induced lung injury. And it's actually indistinguishable with ARDS. It is a cause of ARDS. And so many of the patients who we're trying to ventilate and manage, we may actually be contributing to a lot of their disease process if we're unable to ventilate them safely. And so this actually shows a pretty linear relationship with the plateau pressure associated with the patient and mortality that goes almost essentially up there. Once you get to about 30, and here, it does not mean that you're more surviving if it's less. There are very few patients that were actually down here. They just have really poor compliance or really good compliance. It really shows that like this takes off at around 30. We don't know an exact safe amount of pressure fully. We have some ideas, we have some estimates, but we do know that there are certainly unsafe areas in which when the compliance is so bad in the lung, the amount of force that's required to be generated by the pressure to inflate the lungs, to oxygenate the person, to keep them alive, actually contributes to the amount of damage that's occurring to the lungs. And so that's the concept that I'll just briefly mention with ARDS, is the baby lung aspect, and the concept that there's a large portion of lung that's damaged in ARDS that we just cannot recruit, cannot ventilate. It's just full of fluid. There's some areas in which we can recruit. That PEEP is important in maintaining, reducing atelectasis. And then there's good, healthy lung that if we over-distend that lung, if we give too much volume to that lung, if we give too much pressure, we'll actually end up damaging that. And those who've actually worked throughout COVID would see this time and time again. That patient who's on the higher vent settings, who's hypoxic, you kind of normalize things, and then they continue to get hypoxic, and the vent settings get higher, and then they continue to get hypoxic, and then their right heart fails, and then their kidneys go shot, and then they die. And it's kind of almost a cyclical process that occurs from there. So the idea with ECMO was to prevent and reduce the incidence of that ventilator-induced lung injury. So there's two main trials that are really talked about when we talk about the utility of VV ECMO. The main aspect was the CAESAR trial, which are here in 2009, which was done in the UK, which actually randomized people to receiving ECMO by being transferred to a facility that did ECMO. So it was not the patient would be delivered ECMO at wherever they were. They would be deemed a candidate for the study of the trial. They would be randomized, being sent to the ECMO center, who would then place the person on ECMO and to perform management. However, about a quarter of the patients who got transferred to the ECMO center actually ended up not going on ECMO and not needing to. And so because of that, so technically the statistical significance was true, but as a lot of y'all probably heard from some of our esteemed faculty, that there are a lot of issues with this as a composite score. What are we actually looking at? When you break down the actual mortality, it's not significant. And the reality is because most likely a good portion of the patients didn't actually, in the actual treatment group, didn't undergo the therapy, didn't really need it. So the interpretation for most of the ECMO community at this point was, okay, it probably has some type of role, but we certainly don't need to be utilizing it as a primary form of therapy, and really should be selecting our patients for the sickest ones. And really, we just need to improve management of ARDS. And then the subsequent trial was the EOLIA trial. And this was performed in France. It was a multi-center trial in which we looked at patients who were randomized to receive ECMO or not. The entry criteria that they used is the patient had to be diagnosed with ARDS. They had to be on a ventilator less than 7 days. They had a PF ratio of either less than 80 or less than 50 for an extended period of time, or they could have pretty significant respiratory acidosis. And when you read the trial in the New England Journal of Medicine, it's reported actually as a non-positive study, a non-significant study. If you look, the p-value is 0.07. So the ECMO group, although it had a trend towards higher survival, did not achieve statistical significance. However, there's some problems with that. Is that one, the trial was actually stopped early. It did not achieve the necessary patients required to achieve power. The reason it was stopped early was because the Data Safety Monitoring Board made the decision that by the determined pre-defined variables was that if the trial was not achieving significance by a certain amount of date, they were going to stop it, saying that we don't want to continue a therapy that may not work. However, on the actual analysis, one of the problems is that 30% of the people who were in the control group actually ended up on ECMO. And that's because in France, they found that it was unethical to withhold ECMO in the setting of this patient who would be dying. So patients who were in the control group were allowed to be put onto the ECMO group. And so really, is this a study that is adequately comparing and controlling the difference between these two management strategies? And when we actually look at the supplemental analysis and look at the probability of survival without treatment failure, meaning without having to be crossed over, so otherwise you would have died, it tells a really different story of a pretty significant large group and aspect of that. So what it really kind of emphasizes is that ECMO probably has a role in the management of severe ARDS, especially with the concept of patients who have significantly poor compliance, who can't safely be managed and ventilated. However, it should not be a first-line therapy. It should be something that is understood as a role in patients who are on severe and high vent settings, but you should do everything you can to avoid it because it has a high amount of complications. It's heavily resource intensive. And we'll talk about one of the examples of this. This was one of the first patients that I put on VV ECMO. She had COVID ARDS. And when she came in, her X-ray was here, her PF ratio was about 55 at that point. Her compliance was incredibly poor, but she had only been on the ventilator for a couple of days. She was transferred from an outside patient. She had very minimal comorbidity. She was 45 years old. She was cannulated on ECMO, actually extubated ultimately, and on day 31 is essentially breathing on room air. And so this patient, with the ventilatory requirements that she was on, she almost essentially probably had an 80 to 90% mortality, but from here she ended up actually walking to rehab and walking out of therapy and moving from there. So the question will always be, who is the right person to put on? Who actually needs it? And that's one of the biggest difficulties that goes into it. And it's also understood and recognized now that there were a lot of patients in the earlier trials, even back in that 2008 trial, that we probably didn't even give a chance to live. Back then, and even up into some of the earlier trials, the longest run that most people would usually do on ECMO was about 2 to 3 weeks. And if you weren't showing significant improvement at that time, they usually withdrew and took you off. There was someone actually out in at the Kaminsky Institute in Sweden, and he had pushed those limits and actually had patients on for like 40 days, 50 days, and realized a lot of people that we probably thought didn't make it were. But now we come with an ethical question and a concept of, we can't provide this level of an amount of care and support to every single person. So who do we do that to? I don't have a great answer for that. It's an ethical issue and an ethical problem, and we'll talk about that a little bit more in a second. So when it comes to cardiac support, here's the main problem with cardiogenic shock is something occurs to reduce the cardiac output, that drops your pressure, that drops the coronary perfusion pressure, that causes end organ damage, kidney damage, liver damage, brain damage, that leads to actual further ischemia because of the decreased coronary perfusion, which leads to more myocardial dysfunction, which leads to worsening cardiac output, which leads to multi-organ failure and spiral and ultimately death. And one of the only other therapies that we have in management of this that's not mechanical circulatory support is vasopressors and inotropes. And one of the main issues, if we look at the days prior to PCI, we still had inotropes and pressors and things like that. Almost 90% of the people who came in cardiogenic shock, especially from an acute MI, died. And so that mortality has been decreasing a lot recently, which we'll talk about. But the issue is that adding inotropes while increasing the cardiac output actually increases the demand of oxygen to the heart, which then causes more ischemia and more issues. And so some people can be supported with a little bit, maintain that organ perfusion, you're not damaging the heart that much. But at some point, the heart won't be able to be managed adequately, and we're actually causing more harm than good. So that's kind of that same concept of, yes, the ventilator is useful and it's important and it's helpful, but also when is the point at which it becomes harmful and our own intervention is actually becoming an issue. And the concept of mechanical circulatory and ECMO is that when that cardiac output is decreased to the point to where we can no longer safely manage it, if we offer some form of extracorporeal support or mechanical circulatory support, we can support the perfusion to the other organs while we intervene upon the heart, allow the heart to recover, to rest, or some other type of therapy without getting to that multi-organ failure stage. So one of the ways that I like to describe this, because especially in the VA literature, there is not a lot of good data. Okay, we'll talk about a couple trials, but there are really limited trials in terms of the implementation, especially of ECMO in this. And if you actually look at the implementation of the Impella, none of those trials were actually clinically significant in showing a difference in mortality with the addition of it, especially in acute myocardial infarction. But we still do it, and we'll talk about that in a second. So one of the things to know is that historically, mortality of cardiogenic shock incredibly high. Probably the thing that made the biggest difference in improvement in mortality in cardiogenic shock was actually PCI. Actually intervening upon a STEMI, so a true acute coronary surgery. I'm not talking about outpatient stents and things like that. Talking about a patient coming in with an acute myocardial infarction, ST elevation, achieving reperfusion, allowing that person to essentially not end up with heart failure and not sustain in cardiogenic shock and recover. And our mortality had been steadily decreasing with the implementation of that and use of that. And then something happened in 2008. In 2008, the FDA approved, in 2007 and 2008, the FDA approved a whole bunch of mechanical circulatory support devices. They started to approve the Impellas and various other things, and they started being utilized. And so we saw a very quick drop in cardiogenic shock mortality and outcomes, and then a rise back again, probably from the overexpansion, overutilization, and poor patient selection and management. And I don't really know where we are right now because this data is actually incomplete, but I actually suspect it's probably increased up. Now, one thing about this graph is that we're zoomed in. Okay, we're zoomed in quite a bit with a scale that is not entirely appropriate. When you take a step back and look at the actual overall trends in cardiogenic shock and cardiogenic shock management, yes, we see a decrease in the mortality in cardiogenic shock, especially from acute myocardial infarction. And around 2007, 2008, there is a little bit more of a decrease, but it's not that big. So how much is this? So the question was always asked, how much of this mechanical circulatory support actually really helps our patients? And subsequently, we've also been seeing the rise of heart failure as the cause of cardiogenic shock, which is not really something that's entirely reversible. They've usually reached their end stage of their heart part. And so that's why a big part of why our mortality of cardiogenic shock is going up, because it doesn't matter how much ECMO you're on, doesn't matter what impellers you have, if your heart's not going to get better and you can't get a transplant, you're not going to live. And so that's part of one of the main issues. How does it actually work though? We don't have a great data. We'll talk about the couple. I don't have enough time to talk about all of VA ECMO and all this other stuff. So what I'm going to focus on is ECPR over the next slides. But just to briefly talk about, there are a lot of utilities of VA ECMO in patients. And there's something important to note. This is the data from the Paris group that probably is the largest group that utilizes ECMO as mechanical circulatory support in the world. And they do, it's essentially their primary method. They do not think impellers are useful. They think they're an expensive, ridiculous waste of money and disagree with our entire US approach in that because they're French. And one of the main things to know is that they actually separated out by all the different, this is just observational data, by the way. Nothing truly studied, just prospective observational. They separated out all the different disease states, the mortality associated with it, and also the presence of whether you were in arrest when the cardiac support was put. So was it ECPR? So as you can notice, the light blue lines, which is when patients were in arrest, significantly lower than almost all the others, right? So your outcome, of course, if you were in an arrest is so much worse. But the mortality improvement for a lot of other things is actually not that bad. Some of the ones that I'd like to point out, things like drug overdose, arrhythmic storm, primary graft failure, dilated cardiomyopathy, all of these ones actually do have an endpoint, and pulmonary embolism. They have an endpoint. Pulmonary embolism can be to removal, either endovascularly, surgery, or some other form. Arrhythmic storm, we can intervene with electrophysiology, address that. We can adjust some of the medications and drugs and get that patient under control so that they're perfusing by the time we take them off. Drug overdose, right? It's going to be metabolized, presumably. And so if at some point you can support them through it, it's okay. Dilated cardiomyopathy, if the patient's a candidate for a heart transplant, they'll be able to survive to their transplant a little bit longer. And then primary graft failure, which is for transplanted hearts, you actually can support them, prevent further ischemia of the heart while you adjust and manage the primary graft failure. And so once that's improved, they can have better mortality. And so the things that don't really work that great is the things on the right-hand side. So septic shock, post-surgery, some other random unknown etiology because the person essentially died and they don't know why and they're in shock. These don't have great and good outcomes that are much better than the baseline epidemiology of what we know in the mortality of those patients. And so it's really kind of about what are we utilizing it for? And I don't think we have a great management and consensus, and almost all the recommendations right now are all expert consensus based. The American Heart Association still recommends VA in patients in cardiogenic shock, but it's not really based on a lot of data. And that's kind of the main thing to talk about that. So what about one of the more recent studies that actually was a randomized controlled trial that came out this year, a couple of months ago? It's the ECLS shock trial. So they randomized people to receive VA ECMO who were coming in acute myocardial infarction shock and cardiogenic shock. They would either put them on ECMO while they're in the cath lab, or they would intervene upon them. They'd be in cardiogenic shock after the cath, and then they would put them on mechanical circulatory support. This study showed no significant difference between the ECMO group and the control group. And a theme that you'll kind of see here as well too is that there was about a 30% crossover of patients who were in the control group that actually received ECMO and that survived. And so it's a constant problem and an ethical conundrum in creation a lot of these trials in which the communities of physicians and experts believe that this therapy works. So how can you actually have a trial if, as an investigator, you assume your therapy works and you're not going to withhold it from something else? So it's very hard to actually study a lot of this. I would argue that this was probably something we shouldn't do. This was the indiscriminate utilization of ECMO in patients who are in cardiogenic shock that showed up with an MI. It probably isn't going to help. What's going to change their mortality really is, are you able to actually intervene upon their lesion? Are they going to have a recoverable heart? Are they going to have a chance to an outcome? And also, half of these people were in cardiac arrest when they were put on ECMO. And so so much of the data in the studies are just like very frustrating. It's really hard to actually glean what is the role and what's the utility. And so with that, I'll transition a little bit to eCPR, which is much more applicable to us in the EM and everything as well. It's hip, it's new, it's expanding, it's sexy. There's a lot of procedures involved. You're doing it right in the ER at the bedside. You're putting someone on who's essentially has no pulse, and you're then starting to perfuse their organs with an extracorporeal device. They often achieve ROSC after that, and it seems like a win. The idea behind that comes from the concept that when we have low flow times, so times in which the heart is not adequately pumping perfusion, so you're in cardiac arrest, but you're having some form of perfusion by at least CPR. Usually when these studies are performed, something like a Lucas, something that's providing a robust, significant amount of CPR and perfusion from there, and that's kind of deemed the low flow time. So you arrested, and almost all these patients had very minimal no flow time, meaning your time to CPR was like 5 minutes, like right away. All these studies were done in Danish studies or in US systems in which people were able to get to an intervention and CPR right away. And then once they had CPR, they had good CPR. And their outcomes, when you have that, our outcomes are not that terrible, right? If you are in a place in which you can actually intervene upon that person and they're having a myocardial infarction, and you are able to perfuse them until you get to the intervention and support them, they're actually going to have a decent neurological outcome. The light blue line is the intervention with the addition of eCPR. So the idea in these early studies, which are very controlled studies, was that if we can maybe extend the time in which someone will be in that low flow state so that they can still have a favorable neurological outcome. There's not that many people, okay? Only 100 people were in the study from before. It's all primarily from research of a couple of institutions that have a very specific system in a way that this is done, and I'll talk about that, why that's important in a second. But I think the concept of the idea is, yes, if you can prevent that person from having poor perfusion to their brain and to their other organs by getting to some form of extracorporeal support early, you can maybe extend the amount of time that we have to get that person alive and maybe give them an outcome. Because right now, our out of hospital cardiac arrest mortality is like 10%, right? 5-10%. It's terrible of neurological recovery. And so the first trial that looked at that was the ARREST trial. This is from a group out of the University of Minnesota, where they randomized people to receive ECMO or not. Essentially, they have a very robust, coordinated EMS system with the hospital that was providing the ECLS. They had on-call ECLS providers that could cannulate and put the patient on ECMO within 10 minutes of actually seeing the patient, which is astonishing. Their transport times were typically less than 20 minutes. And essentially the person was only able to be enrolled if they had bystander CPR and everything from there at that point. He showed that there was a pretty significant increased mortality. Essentially the out-of-hospital cardiac arrest baseline was around 10% of neurological outcome. That's good. It rose to about 30-40%. And everyone was like, that's ridiculous. Right? There's no way that that could be the case. And it spurned a lot of further studies that came from that. And one of the big things about this is that this guy actually was a large portion of the talk of the ELSO conference this year and talked about how he really believes that this would allow us to change the outcomes of cardiac arrest and out-of-hospital cardiac arrest. And I'm going to put the pause on that in a second and kind of tell you my thoughts as to why. There was a subsequent study that was performed, published in JAMA, that looked at a single center in the Czech Republic that randomized people as well. Part of the problem is that in the US study, they did randomize people to ECMO, and the people who weren't in the ECMO group did not get ECMO. They died. Every other study in Europe has not allowed that. People were able to cross over into ECMO because they felt it was unethical to withhold a life-saving support and device, and they actually find it fascinating that the US allowed that. However, that's kind of where we see a lot of the issues, and so from here, there's still no crossover, but if you look, or there's no significant difference, but if you look taking out the patients who crossed over, it probably would have pushed it over. But again, these are tiny, tiny studies in which your fragility index, if you've heard it talked about that, is incredibly low. Like a couple of patients might make the difference in statistical outcome. So we really can't say what's from there. There have been 3 trials that are the randomized trials for ECPR. And from the pooled analysis of all of these patients, the argument is yes. All right. If you perform ECPR within a certain amount of time, the person has good access to bystander CPR, their low flow time is not that long, and they're not getting ROSC within about 30 minutes, there might be an indication for ECPR. The person will probably have a better neurological outcome, but that's not the whole story. The whole story, which I really appreciated as the big counter argument at the ELSO talk, was that it's not that simple, all right? Actually creating this as a systemic problem of a cardiac hospital arrest. It's not just the concept of ECMO. I think we can say putting someone on ECMO who's having a hard time with an arrest will probably perfuse their organs, give them a better chance of a neurological outcome, but the amount of resources that it takes to implement that, the amount of coordination with your out-of-hospital cardiac arrest management and system and getting the patient transported to a place that can do it, allowing that person to be put on as quickly as necessarily as possible, is incredibly difficult and complicated, and probably why it's been very hard to replicate a lot of this. The guy in the UK, Nicholas Barrett, was actually mentioned. He was like, their EMS system won't even transport a patient in cardiac arrest that has until 45 minutes. So that's their policy. The physician groups don't agree with that, but that's what the EMS policy is. And so after 45 minutes, he's like, if they come to my hospital, there's no way I'm putting them on ECMO, because the reality is that they're not going to have a good outcome. They've been working on this person in the field for a very long time. And I would argue that our rates of bystander CPR, our rates of getting to a low flow state in a short amount of time, is just not there. We need to focus our resources and our money in a lot of the outpatient management and the public health aspects of preventing this type of stuff, rather than trying to spend a whole bunch of money to save a couple people. And the rationale that I argue behind that is that there's one kind of a little bit more elegant study that looked at a single center in the volume change over time. And the argument was, well, okay, if we can get experience, if we can improve the system, if the system can actually work really great and implement it super well, will we improve our favorable neurological outcomes? And the answer has shown that while the volume has increased of putting people in ECPR, the actual amount of favorable outcomes has not been that great. So are we tying up large amounts of resources in patients that are going to have extremely prolonged and protracted hospital stays and ICU stays of like 3 months, 30 days, and extended hospital stays requiring long-term care and management support for a couple of people? I don't know 100%. I think that there is a role for extracorporeal life support in ECPR. Don't get me wrong, I do it, all right? Have I put someone on in an ECPR fashion? No. And the reason is because I don't think that the stars can align that frequently and that often for it to make it worth it for the patient and for the system and everything that we can do. And I think that maybe for right now, we should be spending our resources and our money on other things that can maybe improve other management and outcome. And I understand that's a double-edged sword too, because I also didn't really say that much with VV ECMO, and that I'm a little bit more believer in that point. But that's primarily because right now the choice between having a ventilator and having a significant amount of morbidity and prolonged ventilation and all of that is also a tax on the system and other issues as well. And the actual rates of letting people go is not that high. And so I think in patients who are really healthy, young viral pneumonias who get this severe ARDS from that instance in the setting, they actually can have pretty good outcomes. The patient that I put on most recently actually was in a traumatic accident. He's actually still on right now. He was in an ATV accident, a little bit of a extra sauce and stuff while he was doing that, and decided to have an argument with the tree, and he lost. He ended up in the hospital with significant multiple rib fractures, a giant lung laceration. He was on oxygen, like 2 liters, ambulating, doing well post-surgery, but they were worried that his retained hemothorax was going to get infected. And they started to show signs of that. So they took him to surgery, and then he aspirated all of his dead lung into his good lung. He ended up being hypoxic on pretty maximal vent support settings almost immediately after that. He had a cardiac arrest during that hypoxic episode. I waited to see if he was going to have some neurological recovery. He showed some signs of neurological recovery, so we put him on ECMO. And then from there, with the idea of that, we're only ventilating 1 lung at this point, and the amount of pressure and support that was required to do that was going to damage that lung. What he had left just could not be managed. His peak pressures were in the 40s. We just could not do that. And also knowing the natural progression and process of aspiration is the compliance usually gets worse. Even after the further injury, he had some underlying pulmonary contusions. He had more CPR and things from that point, and he was probably going to get a pneumonia. And all of those things happened, and he did. He's now kind of in more of the recovery stage. And so I think that there is a role for VV ECMO. I think we're still trying to figure out who that patient is and what it's for. But I think that the large proliferation of VV and VA ECMO very rapidly since COVID is something that we should be very cautious and dangerous and could be very dangerous. And especially when it comes to VA ECMO, we may actually run aground of running into the same problems that cardiology is having right now, where we have a device that we're utilizing things on patients for that may not necessarily glean a significant meaningful benefit from it. And we have to really ask our questions, why, if you really ask the question, why did ECMO proliferate so much after COVID, other than the fact that people were able to see it and utilize it more, it's really driven by the companies. Companies actually started going around and being like, here, you can buy this, put this person on, see how easy it is now. It's reached that level of simplicity actually in which what's required to utilize it and do it is not that much to get started, but the long-term management, the correct patient selection, all of that really isn't taught and pushed. And so we see a lot of proliferation of people wanting to do it without really kind of understanding its significant limitations. And so I think my hope is that we kind of hold back on a little bit of that, still continue to do trials, still continue to advance the therapy itself, right? The goal ultimately is, there are people that are actually working on the concept of reducing the cellular injury after cardiac arrest. And so if there's a way that we can do that at a more molecular level or microcirculatory level, then maybe it does make sense so that when the person is reperfused by ECMO, they're not going into massive organ failure after, and they're not having neurological injury because we improve it in other ways. And so I think that it requires a lot more advancement. The amount of resources that's necessary to do a lot of it at the rate that we're currently increasing it at worries me a little bit, and that's pretty much kind of from there. But I think that there's a lot of opportunity. It's pretty interesting stuff. It's pretty fascinating to manage these patients for a significant amount of time, and it's quite a roller coaster to do it. So with that, I'll kind of leave it with any questions, and we'll go from there.